and to welcome old friends and welcome new friends. And I really do thank you for making time in your busy schedules. I know it can be difficult in the middle of the afternoon. You've seen some of the etiquette slides. Dr. Kale, can you hear me? Yeah, okay.
Yes, yes.
Okay, I can turn up the volume a little otherwise. So please keep your videos on if you can, and remember to be muted when you're not speaking, and to use the chat for questions or to put your hands up and speak. It's just when the numbers increase, we don't always see everybody on the screen. So welcome again, and thanks to Raju and Shri for all the work at the background to set this up. And I'm going to just start by giving you some feedback on the recent evaluation that we did, just so you can see what people have told us. So I'll try and go very quickly through that, and we might be able to share the slides later so you can look at it in a bit more detail, because I don't want to take up too much time from the meeting, the main meeting. So I'll just share the screen. Hopefully you can all see that. Okay. I hope all of you received the survey through WhatsApp and email that we sent out in July, late July. So we have, actually, I'll just put it on slideshow, sorry. We have 91 people registered in this program, so a large number of registrants. Unfortunately, the response rate was a little lower than we might have hoped, with 18 responses. Just by way of background, we know that we have a mean attendance at these sessions of 26 people, a range of 17 to 37. So there's it fluctuates. There's no particular trend. Our lowest two sessions were earlier on, and then the later ones have been around the high 20s in attendance. Now, the topics of the survey was what worked well, what were barriers, did people feel that a national, international forum like this was possible, or did they want it to be a little more localized? What areas would they like to learn more about, and there was a list of suggestions, and then what topics were not mentioned and other comments. So respondents felt that what was working well was the schedule and the topics, and that there was engagement, and the presentations and discussions were good. They appreciated the opportunity to hear from clinicians in India and Australia and to have the joint learning. They complimented Pallium on the organisation, and also complimented the chairing of the meetings, and appreciated that we tried to get engagement. So, you know, there was, we have been worried about the degree of engagement and discussion, but in fact, the respondents gave us some reassurance that there was a reasonable amount of discussion happening from their perspective. So we appreciated that. Barriers, I guess, as expected, the clinical workload and the time of day was an issue for many clinicians in India. And, you know, unexpected events arise, emergencies, and sometimes just in the busyness of the day, people forget about the session happening. In terms of the timing, though, 56% were happy with the current time. About a quarter preferred a little later, 5 o'clock Indian time. And a quarter of the respondents also suggested a shorter session. There was a variation in whether we should keep going with one session a month. 50% or so thought yes. 35% actually thought much more frequent would be useful, even twice a week, weekly, fortnightly. So there seems to be an appetite for increased engagement. That one person thought perhaps every couple of months. I don't know, where the responses came from. There were Australian respondents. Most of them were, I think, from Indian participants, however, but I don't know exactly who was thinking what. We asked about how we might increase interaction. So these were some answers: more practical sessions, more breakout sessions, shorter presentations, avoiding didactic presentations. They really wanted case presentations from an Indian service, and really base all the discussion in cases as much as possible, practical, interactive, and cases. So that's really helpful. People did feel, on the whole, 78% felt that it should be national or international and not limited just to one area of India. We wondered whether that might increase interaction by having it a bit more localized, but people like the national flavor and the international. 89% felt an international community of practice was possible. And we also wondered whether having new members coming each month might sort of limit or make it make people more hesitant to contribute. They're not getting comfortable with the existing group, but people said no, they would like to keep it open to new members. There was in addition, there was comment that we do need to be careful about, the guidelines need to be contextualized and adapted, and that we have to always be mindful of that. And I think from the Australian side, we certainly wouldn't expect that any guideline that we share would be applicable just as it is. Everything would need to be adapted for the Indian setting or vice versa. So the other comments were around how to increase engagement and participation, when people considered maybe having some awards. Definitely thought it could continue, that it's informative, and there was a possibility perhaps of recycling the topics, that we don't always have to come up with new topics. And then the rest of the feedback was about the specific topics of interest and what within those topics might need to be covered or what they would like to be covered. So that was really helpful for us. And if we do have presenters talking about these topics, we'll definitely share some of this feedback with them. So that's all. I just wanted you to see what the feedback was and share that with you. Would anyone like to comment at all before we move on to the presentations for the day, or anything people would? And I think the survey could still be completed. Is that right, Raju, that it's still open?
Yes, Dr. Auditor, it is still open. So
yeah.
anyone still wish to give the feedback, they can do it, right?
Okay, great, thank you. So we might even send it out again just to encourage people to give us their thoughts, because it's really, really helpful for us when we're trying to develop the course. So thank you very much to those who have responded already. Any comments from anyone before we move on? Okay, feel free to put them in chat if something does come to mind. All right, well then it's my great pleasure to introduce our speaker for today, Gauri Godbole. Now, Gauri, is that the right way of saying your surname? Okay.
Yes.
Thank you very much. So Gauri, actually, we met Gauri through Pallium India, because Gauri wrote to Pallium to look at how she might perhaps get engaged with the work that Pallium does, and Shri kindly connected you to me. So Gauri is a clinical pharmacist who works here in Australia in New South Wales in aged care and mental health pharmacy. Now, her practice interests include aspects of geriatric medicine, research, teaching, both health professionals and consumers. And her scope of practice may be of interest to any pharmacists who are joining us from India. For example, she teaches in a program for falls prevention and advises on many national and local committees, such as the New South Wales Therapeutic Advisory Group, the Night Sedation Guidelines Committee. She's been awarded for a contribution to pharmacy practice and has achieved her advancing practice pharmacist credentials in geriatric medicine in 2019. So we're delighted to have you talk with us today about Delirium, Gauri, and over to you.
Thank you so much, Odette, for such an elaborate introduction. I'm humbled that coming from you. I'm very humbled. I'm just going to try and share my screen in a second, if it works. Is it working? Yeah, I think it is. Yeah, fantastic. So yeah, no, thank you so much for this opportunity. I guess to present, of course, but going by ECHO's motto, I guess, to teach all, learn all, I guess. And I had to look that up actually, by the way. But I'm here to learn more than teach, I guess, and it's definitely a two-way process. So thank you again for that introduction. My practice in palliative care is actually fairly new. It got put in my aged care and mental health portfolio not long ago, so about 4 or so years ago. Therefore, I'm still also learning and developing those skills. So quite eager to learn. I'll try and keep this presentation for about 25 minutes because Odette and Nisha also have really good engaging cases. Okay, so I kind of pitched this presentation more as to management of delirium from a palliative care perspective, but coming from a geriatrics background, apologies, if it sounds very Jerry's related, and that's where I would really like to know your palliative care input from palliative care background. So what is delirium? I guess I just wanted to keep it a little bit simple. There are many terminologies used for it. So it's basically an acute onset and fluctuating course of consciousness, basically from which lasts from hours to days. So as compared to dementia as a cognitive impairment, disorder that's like from months to years. This is acute onset basically and has a quite fluctuating course. There's a change in cognition, of course, memory impairment, disorientation, and language disturbances, or perceptual disturbance like misinterpretation, delusions, or hallucinations. The causes for delirium are mostly reversible. We'll discuss that in a minute. I guess the next slide, in the next few slides, I just wanted to emphasize a lot on what causes delirium and how we can reverse it rather than treating it per se. Just out of interest, there was a systematic review that was published not long ago with prevalence of delirium. Apparently at discharge it was about 40%. So 40% of people had some sort of delirium or cognitive impairment present, and it only decreased to around 20% by 6 months. So that's where I just wanted to also mention that there is strong interconnection between delirium and dementia, in particular in geriatrics. It's not that clear as to which is precursor to what. So people with dementia can have delirium superimposed on like from time to time with the physiologic changes that they experience. Please just raise your hand or like put comments or just speak out, so that would love to know your opinions as well on that. So I just wanted to give a bit of an Australian perspective, I guess, on its prevalence. In 2019-20, the rate of delirium as hospital-acquired complication, we call them HACs here in Australia, was 35.7 per 10,000 admissions in Australia. Now, it appears, 37.5 35.7 whatever per 10,000 is not as much, but the load on healthcare systems is quite enormous in terms of, I guess, resources and caregiver burden, and actually burden to the patient themselves because of delirium. Delirium is even more common in surgical patients with incidences as high as 50% that post-surgery period, I guess. And we discussed the relationship between dementia and delirium already. This is from a Scottish guideline. So about 30 to 85% of hospice patients experience delirium at some point of their admission. It's often reversible, but it's diagnosed quite late. So again, please chip in, but what has always been kind of drilled in my practice is that delirium is a medical emergency. It has to, like, the patients have to be looked at pretty much straight away. Of course, that might not be possible all the time as well. So identifying delirium could play a very important role there. Now, just going to causes of delirium. As a student, I remember, learning everything as a mnemonic. So I'm like, there has to be a mnemonic for this. So I found a mnemonic, deliriums. So just to keep it a little bit simple, I guess, so drugs, of course, or lack of drugs. So drugs including opioids or anticholinergic agents, corticosteroids, benzos, antidepressants or sedatives, they are all implicated. Or withdrawal, so lack of drugs, so like alcohol, sedatives, antidepressants, or nicotine withdrawal as well. We just had a patient not long ago, was on a benzodiazepine long term, so was on diazepam at that as well, 5 milligram at night regular. And one of their community clinicians thought that, oh, diazepam in older people is no good. It has got long half-life, we should deprescribe it. You might have heard this word quite often now, deprescribe or detrial a medication. So the cold turkey stopped diazepam. Now, it being a longer acting medication, we would think that, it would linger around in patients' bodies for longer and there wouldn't be such shocking, I guess, fulminating delirium precipitated. But unfortunately, the patient came to hospital pretty much the next day with pretty florid kind of hallucinations and delusions. So something to remember as well in terms of longer acting agents as well. Of course, dehydration, constipation, urinary retention, and in our palliative care patients, uncontrolled pain in particular can all precipitate delirium. In particular with electrolyte disturbances, I have seen a fair few patients in practice with hypercalcemia in particular, in advanced, I guess, cancers. Unfortunately, uncontrolled hypercalcemia can precipitate it as well. Infections, hypoxia. Other thing is, I guess, deprivation of sensory or sensation, basically. So if their glasses are not fitted properly, or hearing aids, or they're just a bit disoriented due to new environment, that can also precipitate delirium as well. Is there anything, Odette, you would like to add? I think it's pretty much covered, isn't it?
I think so. I'm wondering what people feel might be the most common in a palliative care patient group, but if there is a most common. Any comments? Nisha, I'll ask you, you know all about this.
So I would think untreated pain can be a trigger, which I'll be talking more in my case.
Hello, Odette, Anil here. I would almost suggest that just the process of being admitted into hospital, I see as a very common cause. So that I think would come under environmental factors, perhaps, the change in where they are.
And the need to just constantly reorientate, especially the elderly at that early stage. And I think I don't know in India, but in Australia, I think the noise level in wards can be quite extreme sometimes, which I think is quite difficult for a confused person to cope with.
Can I add to that? I think in our setting, we do see mostly, as Nisha said, untreated pain, yes. Drugs, probably. Many of the drugs, including opioids and other chemotherapeutic agents and stuff. Constipation and retention of urine is another common cause that we come across.
Definitely.
Absolutely. There was another, sorry, please
Agree.
go on.
Koshia, agree with the comment that it's retention of pain, retention of stool, urine, the environmental factors. Dehydration is another thing which we see more often in India, where the fluid status is also not right. And the electrolytes, many of them are in hyponatremia.
Okay. Thank you.
That's a great point, actually. Yeah, definitely. I guess, we'll discuss about management strategies in a second. But there was another thing that came to my mind. We had a patient not long ago. I was telling Odette about it. This patient did have background dementia, came in with delirium, and very upset the minute they entered that room that they were in. And as Dr. Tandon mentioned, this patient kept saying to us that, there was a green monster in the room, and we were like, there isn't any green monster in the room. And apparently they were thinking that a little green indoor plant at the corner of that room was a green monster. So absolutely, change in environment is a really big factor. Excuse me for a second. Sorry about that. Okay, so just going to types of delirium, I guess I just thought I should touch base on that one. So usually it's kind of very roughly classified as hyperactive, hypoactive, and mixed pattern. So with hyperactive being increased arousal and agitation, hypoactive being quiet and withdrawn and inactive state, and then of course there is a fluctuating mixed pattern as well, where patients can be hyperactive or hypoactive. That's where I just wanted to open it a little bit. What do you think might be more common, hypoactive or hyperactive in the type of delirium?
Hypoactive delirium is more common in most setups.
Yep, absolutely. We would think that, on a ward level, a lot of times people who are, I guess, we notice them more often are people who are really agitated or wandering, or particularly in geriatric setting. So you feel that hyperactive might be more common, but absolutely right, hypoactive delirium is more common form, and it's quite easily underdiagnosed, or missed, basically, because it can be easily confused with perhaps an underlying depression as well. So I guess in terms of assessment, quite accurate history from someone who knows the patient is quite important. So what's this patient's baseline from how they are usually to how they are now? Is there any other, I guess, method you might use in practice more often for a quick assessment?
In our practice, it's almost the same. We don't use. This is the recommended. CAM might be in an ICU setting probably, and
Okay.
MMSC might be the easiest tool to use.
Correct. Just I wanted to just quickly open for a minute, just a bit of a debate, I guess, that always happens in our practice. At least we have patients coming in with delirium, so it's an acute confusional state, and then they get their MMSC done. So obviously it's going to be like, they're acutely unwell, and the MMSC is something whatever 18 or 19, and then a decision is made that again, I'm talking more about Australian setting, my apologies, but a decision might be made that, they're not able to look after themselves at all, and then placement to a nursing home and so on and so forth. I'm not sure, like, what your experiences of using MMSC in acute setting is really. In our I guess hospital now, they're moving a bit away from it. They stick more to CAM, and then of course talking to the family members just to gauge that baseline. So investigations, I just wanted to quickly include this slide as well. So full blood count, of course, and then biochemistry, particularly calcium levels. Check for infections. So in mostly UTI, a lot of times UTI and pneumonia in older people. Review medications and stop unnecessary polypharmacy. So that's one other thing, polypharmacy in itself is not a bad thing necessary. The unnecessary polypharmacy is something that we should be looking at. Usually how I look at deprescribing is, how we trial a medication. So a patient comes in with an ailment, we trial a medication, and then we detrial a medication. So I always look at deprescribing as detrialing. So, if the patient is not agreeing with that detrialing, we can always reintroduce it or suggest reintroducing it. So that way, I guess, you do keep that little, I guess, opportunity to intervene, that window open in that case. Sensory impairment, as we mentioned, if they're wearing their glasses properly, or if they've put their hearing aid properly or not. Check for opioid toxicity. I think it's quite important in our palliative care patients. So drowsiness, agitation, myoclonus, or hypersensitivity to touch. In my practice, like as in our hospital, we usually tend to reduce the opioid dose by about 1/3, or we usually aim to 1/3, or say perhaps even switching to another opioid or recycling opioids. I was just hoping to know your, I guess, in your practice, how you approach it. Like if you're trying to recycle opioids, do you like kind of slowly wean the first and then reintroduce the other one, or like overlap basically? Any comments?
Gauri, in my practice, actually, we usually will reduce the equivalent dose, but it will be an abrupt change straight from one opioid to another without an overlap.
Okay, sure.
Perhaps almost, sometimes it feels like the most important thing is trialing a reduction in the dose of the opioid is important.
Yep, sure. Thank you, Dr. Tandon.
Just to add on to that, I thought
yes, absolutely.
So we try to reduce the dose. As we don't have much options, we are not really bothered about rotating the opioid or choosing another opioid. But here in Pallium, we have methadone, so probably we'll keep the SOS doses of one opioid till because it is methadone, it will take some time. But otherwise, most of the centers do not have any other option other than injectable or transdermal fentanyl. So probably dose reduction and supplementing with antipsychotic or reversing the reversible might be the only option for other.
Sure.
And I think also in the presence of an acute illness or dehydration or fever or hypoxia, all those other factors may well be contributing to the opioid so-called opioid toxicity. So addressing, as you say, addressing those factors alongside.
Sure. Thank you, Odette. And I guess other aspect is to check for constipation, urinary retention, and or catheter problems as well. So usually, like in our practice here, so for constipation, we tend to use a stimulant and softener as a first line. So our go-to is Coloxil and Senna, as we call it here. And then the second line probably would be macrogols, so osmotic laxatives, and then we kind of reserve rectal treatments as third line, but then I guess, it could be interchangeable as well. If somebody is really constipated, the clinicians might think to go with the third line pretty much straight away. So it really depends on how bad the situation is, I guess. So just continuing with management, I guess, treating underlying causes, it's the mainstay of treatment, I guess, non-pharmacological management, if you will. Somebody really made a cogent point before of mentioning dehydration. So absolutely maintaining hydration, oral nutrition, and mobility are quite cornerstone as well. If nicotine dependent, we consider using replacement patches here or inhalators. So if our patients are used to that that smoking action, a lot of people are quite addicted to that. We do have something called as nicotine inhalators. I just wanted to know what's available in India. Do we have patches there, or what is our strategy for nicotine replacement?
I have no clue about it. Maybe others in the group might be able to answer that question.
We have nicotine chewing gums.
Yep,
And so
yep. Yeah, it's a Nicabate or those chewing gums. Yes, absolutely.
What is nicotine the biggest issue? Sorry, Gauri, to interrupt.
No, please go on. That's a very great point you're making. Yeah.
In India, I'm wondering if it's other agents that people withdraw from when they come into hospital.
Yeah, I think nicotine and many other substances might be.
So
I'm not sure about the replacement part when it comes to palliative care, because very often we get patients in the end of the illness trajectory. So probably that may not actually matter for
Yeah.
most cases. I'm open, like other participants can also pitch in. I'm just focusing on what we have seen here. Might be
It's
different in
quite-
different places in the country.
there's probably some variation across the country as well, and in
Yes.
terms of the types of things that people might be
Yes.
using.
Yes. I think maybe the other participants will be able to pitch in about even the opioid, various forms of opioid might be available in other states, but here, yeah, it's slightly different.
Mm.
Yeah. Dr. David, have you got any comments about opioids? What you do if you think someone has opioid toxicity?
yes, we usually try to reduce the dose, and we just see if there is some underlying kidney problem. So we titrate the dose according to the kidney function test.
And do you tend to reduce the dose and keep it 4 hourly, or do you tend to make it a longer duration, like an 8-hourly dosing?
Yeah, it actually depends on patients to patient. Sometimes in some patients we prefer sustained, in some immediate release.
Thank you.
Sure. That's actually quite eye-opening for me, and that's the precise reason why, I'm here to learn as well. That, things that we might take quite for granted, like just put some people on nicotine patches or give them whatever form of opioid might not be as available everywhere. So that's quite eye-opening. Thanks for sharing that. So I guess anxiety. So I guess in people who are delirious, they could be quite anxious and frightened. So new environment, and so addressing that, reassurance, I guess, constant at that as well, is one of the non-pharmacological methods we can use. Addressing issues with sleep-wake cycle. So like patients with advanced dementia, for example, might have circadian reversal, and what we I guess call as sundowning here. So by 3 o'clock, 4 o'clock, they might start getting a bit more active and then wandering. So wandering in itself, we can't treat wandering. There's, I guess people wander because they can, I guess. But if it is intrusive to other people and themselves, that's when the issues start. I just wanted to ask the group about melatonin and their experiences with it. I guess any experiences with using melatonin for sleep-wake cycle? Do you think it's useful? Do you have melatonin formulations in India at all?
Yes, yes, we
We
get
do.
tablets.
Dr. Koshi, were you going to comment on that, or Dr. Shilpa?
Hi, the only experience I have with nicotine is one of my friends who had severe depression and severe insomnia, and she was not responding to any of the drugs, was started on melatonin. But even after that, that did not help much. So I don't know. That is the only experience I have.
Thank you.
Absolutely. Um, eh, just, I guess, from a very brief experience I have from our patients with melatonin, usually after 12-week mark, if it's not doing anything, we tend to stop it. In Australia, it's now available over the counter, as in, you don't require a doctor's prescription for it, but it's very expensive. It's about $35, $36 per supply. It's quite expensive. A lot of people can't afford it. And also I know some anecdotal studies that again, it might not be as applicable in palliative care setting, but some anecdotal studies were about osteopenia as well. So like patients experiencing fractures basically with long-term use of melatonin. I don't know if anyone has heard of those studies, but definitely with my little work with the night sedation guidelines, we were going through some lit reviews, and there were some probably not as high quality studies, I guess, but there was mention of long-term use of melatonin and Z drugs in particular, so like zolpidem and zopiclone and all those things, and causing fractures. So I don't know whether the fractures were because people were too sedated and fell, and that's why I had fractures. Very unlikely with melatonin. It doesn't cause that degree of sedation anyway.
Hello,
Yeah.
Gauri.
Is Dr. Kai?
Yes, you said reassurance. I would say reassurance to the relatives more than the patient,
Yeah.
because they are more bothered. Delirium causes a lot of mental trauma to the caregivers. That is my observation.
Absolutely spot on. Like, yeah, a lot of times people don't know what's happening really, unfortunately, the only sad terminology given to any such, cognitive declines might be psychosis. In a lot of terms, people think that they have gone a bit crazy, which is not a very nice term. But yeah, absolutely spot on. Thank you, Dr. Kai, for that. And as Dr. Odette mentioned about checking lighting, noise levels, and all those kind of non-pharmacologic things we can do. Talking very briefly about pharmacological management of delirium, just from an Australian perspective, we have no approved drug as such approved by TGA, Therapeutics Goods Administration, to treat delirium. All we are really trying to do to use it as a last resort if patient is trying to be of harm to themselves and other people. So just a very quick case that comes to my mind that we saw a couple of weeks ago. Older patient, about 85 something years old, experienced delirium. They had a fall at home basically and a long lie. So they were on the floor for about 8 hours and nobody noticed. Unfortunately, had I guess muscle crushing injury, had rhabdomyolysis and all those things, and came in with fulminating the delirium, and was trying to actually go in each patient's room and strangle them, sadly. So that's when they're being harmful to other people as well, and of course so much stress on the patient. That's when, as a last resort, we had to use pharmacology pharmacological management. The mantra, I think, for these is smallest dose for the shortest period of time. Therapeutic guidelines is something that we quite often use in Australia. Those are our go-to guidelines for clinical guidance. I mean, nothing takes over clinical experience, but that's just like a bit of a guide that we use. And TGs mentioned that usually one dose is enough, but I like to open it as well. A lot of times one dose is not enough. I think, you might have to do a few repeated doses, say 4 times a day or 3 times a day or twice a day, just to comfort the patient as well. But
drug
I
do
would
you
like
use?
to open this up. Yeah.
Which drug do you use? Gauri?
Drug.
Sorry.
Which
Which
drug
drug?
do you use?
So I'll mention that in a second, but usually we recommend haloperidol, say 0.5 milligram orally. I'll mention that in the next slide, but thank you for reminding. So usually starting low, really small dose of haloperidol, so 0.5 milligram, say as a single dose. Also, there is not such a huge difference between the newer and the older antipsychotics as such. However, the newer antipsychotics, say for example, quetiapine at a small dose might be better for people with Lewy body dementia or Parkinson's, patients who have Parkinson's disease, because the older agents can cause more extrapyramidal side effects as well. I guess so. I'll just quickly go to the next slide in 1 second. But we usually don't recommend benzodiazepines as absolute first line unless we are talking about terminal delirium. Odette, would you like to chip in on that as well? Like say midazolam used in say terminal agitation or terminal delirium?
Yes, we tend to quite often end up using midazolam in that situation, or levomethpromazine. Nozanan is the other one that's sort of antipsychotic, though. And again, the same principle of the lowest dose that is needed. Anybody else like to comment from the Australian practice or the Indian practice? You use midazolam, I think, in India too. Yeah.
Midazolam works. Midazolam works.
Yep.
Pardon?
Yes. Midazolam.
Did you catch that, Gauri? Did you catch?
Yeah,
what
he
that-
said midazolam works pretty well.
Sorry. Okay, great.
Yeah.
Or clonazepam is the other one if you have the patient at home. You have Rivotril in India, I think. Yeah.
Dr. Navish, you are about to tell something.
Sorry.
Yeah, we usually use midazolam here also, and along with haloperidol whenever required.
Yeah.
I mean, one
And
thing
that's
in
mostly-
India, you usually have the patient's families with the patient, don't you? I guess during COVID, I don't know if you noticed more problems with families not being able to be there. Were families prevented from being in the hospital, or could families still come in during the worst of the pandemic? Here, visitors weren't allowed into hospitals.
I think we had a brief period, maybe a year or so, of families restricting to immediate family caregiver. But now it's slightly different. People can come, not like in the past, definitely, but depending on someone is imminently dying, so probably we'll tell all the family members to, immediate family members to come and sit with the patient. And regarding the drug, I think for delirium, definitely benzodiazepines are not the drug of choice. Only after giving a baseline of an antipsychotic, preferably haloperidol. Adding on to that, we'll give midazolam for terminal agitation, but not benzodiazepines alone.
Yeah.
The baseline of haloperidol with midazolam or lorazepam, depending on the availability or where the patient is, but not benzodiazepine as the first line.
Perfect. Also, there was, this is again, I'm not talking about terminal agitation, but There were a few studies that I came across where antipsychotics actually aggravated delirium as well. So this is mostly in patients with that reversible cause that we were talking about of delirium. So as we said, the smallest dose for the shortest period of time as well. Usually we again, in our practice here, we don't tend to repeat the doses of antipsychotics within, say, 60 minutes. For usually what I have seen is that, they might give a small dose of, say, risperidone, for example, 0.25 milligram or 0.5 milligram, say, BDPRN. They might time it, with the sundowning. So they might actually give it at 3 o'clock, for example, when you see that the patient's starting to get restless. Also, one other thing that, we with the Royal Commission, the inquiry into the aged care that has happened in Australia not long ago, consent to these medications has become a really big, I guess, question as well. We do need to get, our patient can't give consent, of course, if they are delirious, but yeah, patients' families need to give a consent. So our prescribers have to call them to let them know what's happening before charting. I don't know whether we have time to discuss that or not. We might be running out of time, but I don't know whether, if there's a similar thing in India at all about consent.
I have a point here. Gauri. Whenever the patient is admitted in a hospice, our hospice, it's an implied consent. So we don't take separate. Of course, one general consent is taken. So it's an implied consent that whatever drugs are required for the betterment patient, we can use.
Sure. That kind of makes sense in, I guess, palliative care hospice setting. Absolutely. Like, the goal is to, I guess, quality
It's
of
for
life.
the patient. Right.
Yeah,
I
absolutely.
don't
Sorry,
think
someone
we
saying?
would necessarily take consent, but I guess we would still try and keep the family well informed about what we were doing, though.
Yeah.
We don't really have a carte blanche to do whatever we think without discussing it with the family.
That is already explained to them. That is already counseling has been done and we have been explained everything. Then only we will do it. We are not in dark. We are not in dark.
Okay.
Okay. I might go to like a quick case. As I said, sorry, someone saying something? Did I interrupt?
Yeah, and Dr. Koshi here. For us, it's usually in the hospital setting, it is consent for sedation as well as restraint we take.
Yes.
But to start haloperidol and all, it is prescriptive in nature. That is what we normally do. But if we want to continue with infusion or something, separate sedation consent is taken.
Sure. I guess, after this whole Royal Commission that happened, if you're interested, I can post you a link later, to see their recommendations. They call anything that is sedative as chemical restraint. So anything that is restraining in nature, that even includes, you might be shocked if I say this to you, if a patient is sitting on a chair and you put a table in front of them for them to not try and get up, for example, that is also considered as a physical restraint. By definition here. So I used to actually work as a nurse as well when I was studying pharmacy those many years ago, just to get, I guess, to pay my fees. And I remember there was a big push not to do that. The minute you put a table or slide a table in front of the patient, then you're restraining them. So yeah, there was a big catch-22 situation. Absolutely. Yeah. Okay, so going forward very quickly. So I have a case study. So here I would really like everyone to participate in this one. So Mrs. DG, she's a 76-year-old female patient, lives at home with son. A history of presenting complaint was increased confusion for the past 24 hours and quite agitated and uncontrollable at times. Her past medical history, she has dementia with an MMSE of 15/30, so quite severe dementia, moderate to severe dementia. High cholesterol, so hypercholesterolemia, hypertension, insomnia, and lower back pain. which is newly diagnosed. On examination, she is dehydrated, quite hypotensive, thinks there are ants crawling all over her legs. So her medication list on admission is she was on 50 milligram amitriptyline at night, amlodipine 10 milligrams in the morning, endone or oxycodone immediate release 10 milligrams 3 times a day when needed, and rosuvastatin, which is a statin, 5 milligram in the morning. What would you like to know? I just want to keep it open it to everyone. First thoughts.
What about constipation?
Yep, absolutely. There are no aperients charted. Absolutely. Yep. Mm-hmm. Anything else? Sorry? I didn't hear you, Dr. Kare.
Constipation, because there is a commonest thing with those elderly ladies who lie down for some time, they will have impacted stool. And that is one of the causes which have found common in these elderly ladies.
Absolutely. Absolutely. Yep. Yep. Any other comments on? Go on. Yep.
How much of the oxycodone has she been taking?
So, well, it says she's on 10 milligrams 3 times a day for back pain. It was just recently started for lower back pain. So 30 milligrams.
The other thing is dehydration with amlodipine. How is she currently?
Yeah, so she is dehydrated, definitely.
And amlodipine is continuing? Pressures are?
Yeah, so she came in on it. Yep. Would you suggest to withhold it?
Yeah, if the pressures are on the lower side, amlodipine needs to be withheld.
Okay. Yep. Would you like to also, I mean, you know, this is again, I've just kept it really simple. I just wanted to hear everyone's thought. We are going to have a detailed case very soon. Yeah. Any other comments on pain management? Like, would you like to see oxycodone 10 milligram TDS PRN as her first line for back pain?
No. That
Sorry?
cannot be first line. That cannot be first line. If you can find out the cause of backache, that's better. Because there is no other mention as to why she has got backache.
That's right. Yep, the cause of backache, I guess. And you know, here in Australia, we are quite big on baseline pain control with paracetamol. If she can actually have it as well. So there is no mention of that as well. We don't know how much she weighs. I mean, if she's a really 50 kilos frail lady, then perhaps a smaller dose of paracetamols to start with might help her as baseline. Yeah. Any other comments on amitriptyline?
Yeah, I was going to ask how long has she been on amitriptyline, and particularly at that high dose?
Yeah. Hi, Penny. Yes, absolutely. Yeah, at that high dose, and like, why is she on it? I mean, upon inquiry, you get to know that, you know, she's on that for insomnia, I guess. But yeah. Sorry, Dr. Kai, you were saying something?
No, these all antipsychotic drugs, they do cause constipation. All of them.
Yep. Mm-hmm. So, yep.
So there is no mention of any thing. To relieve constipation, nothing is being added. Either a stimulant or a stool softener, nothing is there.
Absolutely. Yep, that needs to be addressed.
Because
yep.
With oxycodone, it's a type of opioid. So stimulant as well as stool softener with an elderly lady, it must have been given. It should be given, sorry.
Absolutely. I just want to give one food for thought before we move on. She's 76-year-old lady with advanced dementia. Would you like to see her rosuvastatin continued? Like,
No,
what are we aiming for?
No idea about that.
As in, you know, would you like to, you know, I guess weighing the risk versus benefit for this lady, you know, what are we aiming for? Are we aiming quality of life for her? Or are we aiming, you know, I guess, tight control of her cholesterol levels so that she doesn't have any future cardiometabolic events? Would you perhaps think of stopping it or detrialing it?
Sorry, no comments. I don't know. Any other person?
Anyone else?
I think I would be brave enough to stop it, actually, Gauri.
Yeah.
It's one of the, it's so often continued, isn't it, the statins, but I can't say I can quote the figures on how many life years it might be benefiting her and so forth. I don't know all the cardiology literature, but I think on basic principles, it's unlikely to be doing a great deal for this lady.
Absolutely, absolutely. I mean, if I am the clinical pharmacist on the ward, which I was in this case, I did give that recommendation as well. If you are interested, there is a really nice website called as numberneededtotreat.com, nnt.com. It actually gives all the fancy numbers on, the number needed to treat, to get any benefit of any drugs really. It's a really nice website if anyone's interested. I think I'll move on. I've taken a lot of time, sorry. So I just wanted to end this here with this really nice 4M model. Just wanted to put it out there as to what matters to the patient. I mean, we as healthcare professionals, I mean, particularly me, from coming from more of a pharmacy background, I guess, we look at everything is cured with medication kind of mentality, or we can stop this or start this. But I guess I just wanted to leave you with this little food for thought with this 4M model as to what matters to the patient and families, what are their goals, medications if necessary, using I guess age friendly medication, i.e. with the basic principles that we discussed, mentation, I guess managing delirium, depression, dementia across all settings, and then maintaining that mobility. What matters to a patient. A simple making a cup of chai might be very important to a patient than running a 10-kilometer race, which I'm just putting it out there. But simple things in life might be more important for them than I guess any heroic efforts to do things. So I just wanted to leave it there. I'm sorry I took a lot of time, but yeah, I'll wait around to hear Dr. Odette and Nisha.
No, you haven't taken a lot of time. We've done what we try to do all the time, Gauri, which is have interaction and participation. So thank you very much for your presentation. And I've just said to Nisha not to rush, because my case can always be bumped off the end of this session, because there's probably going to be quite a lot of overlap in all the cases. So we'll hand over to Nisha perhaps now. And I'll just introduce Nisha, who's an advanced trainee in palliative medicine, and I believe dual trained in palliative medicine and geriatric medicine. So a lot of overlap with your kind of areas too, Gauri. And Nisha contributed to an early ECHO session when she spoke about her audit of falls in a palliative care unit in Melbourne. It was the session we did on falls in April, I think it was. Now, I just noticed Dr. Koshi's hand was up. Dr. Koshi, did you want to make a comment?
No, there's no time. So that I just wanted to ask, how does she manage polypharmacy when the patient is under other consultants?
Great question.
That's a great.
She's a pharmacist, Dr. Koshi, so she can give advice, but it's the other consultants like us who have the problems then.
I guess just in two sentences, I would say going on ward rounds with consultants, and I guess, bringing it back to the patient. I guess, what matters to the patient. If you have, as a pharmacist, if you have done a thorough medication history before you go and see a patient and say, there have been studies done where patients actually do want to get off medications, so I guess initiating that discussion, and I've been very fortunate, all the consultants I go on ward rounds with have an open heart to listen to what I have to say. So I guess giving evidence-based responses is very important as well.
Thanks, Gauri. Dr. Koshi, you might have missed the very beginning when I introduced Gauri. She is a clinical pharmacist. So sometimes it's the messenger makes the difference actually. So perhaps we've learned that we need to, if we have some issues around overprescribing, we'll ask the pharmacist to talk to the consultant. Anyway, over to you, Nisha.
Yeah, thank you, Odette, for the introduction. So I'll introduce myself again. I'm Nisha. I'm one of the trainees here in Victoria. So I'd like to proceed with my case. Happy to share experiences, and I'm here to learn as well. And please stop me anytime throughout my presentation. So I'll start with my patient, which I actually recently managed. She was a 77-year-old lady who was referred to us, the Consult's palliative care team, for symptom management, predominantly pain, secondary to a left acetabular and a sacral fracture. So a presenting complaint, mainly left hip acute pain. She also had some history where she reported some chronic back, pelvic, and rib pain as well. So she initially presented to emergency with left-sided hip pain for 1 day in a setting of a fall. She reports was getting up from her chair, tripped on her dog's bed and developed a new onset of pain in the left hip with inability to walk. So she was brought in by the ambulance and required intranasal fentanyl, 200 micrograms and 80 milligrams ketamine. In emergency, it was confirmed to have a hip and a sacral fracture, and she underwent a facial iliacal block with 150 mils of ropivacaine, which was administered. So these are her relevant comorbidities. She's got end-stage kidney disease on hemodialysis, secondary to membranous glomerulonephritis. She had a very recent fall where she sustained a right frontal hematoma, bilateral rib fractures, and also a T3 unstable fracture, which was conservatively managed. She also had a previous history of a stroke where she had residual motor deficits and some cognitive impairment. She had osteoarthritis, hip, knee, and degenerative disc disease, in which she reported to have a chronic pain. And she also had some sensory impairments. So these were her relevant medications on admission, and a lot of them were her medications from a renal disease. She was on escitalopram 20 milligrams, and she was on pregabalin 25 milligrams post-dialysis days. And she was also on tapentadol 50 milligrams BD, which somehow was not transcribed onto her charts on admission. These were her relevant investigations. So her full blood picture was normal. Her eGFR was 6 with a creatinine of 600, which was her baseline. Her septic screen was unremarkable. She had an initial X-ray which did not show a fracture, but proceeded with the CT hip in view of her pain, which showed acute fractures throughout the anterior aspect of the left acetabulum, the left superior pubic rami medially, and a left sacral LR. There were also all fractures that were identified. So she was admitted under the renal team. Orthopedics consulted, and given the fractures were undisplaced, the management was conservative, and they suggested touch weight bearing for 6 weeks with serial X-rays respectively at 2 and 6 weeks. The acute pain service were involved, and the initial suggestion was endone 2.5 to 5 milligrams 4-hourly PRN, which did not have much effect. And the next day, they suggested adding tapentadol 25 to 50 milligrams 4-hourly PRN, which the oral ability for her to take medications started to get unreliable in view of a changing mental state. So that became a problem, and subsequently on the 27th, which was 3 days post her admission, sublingual buprenorphine 200 micrograms 3 hourly was introduced, and endotependidol oral options were seized. On the 4th day, she continued to be unstable. Her pain was not managed. She was not tolerating sublingual buprenorphine, and the nurses were finding it hard to actually provide this administration, mainly around the coordination of the sublingual administration and her mental state. She started to develop a new onset of delirium, and this was fluctuating with a hypervigilant state. She was combative with staff, trying to climb out of the bed. A sleep-wake cycle was also reversed. And in the first instance, the team managed her with IM olanzapine. And these occasions were based on trying to get some tests done, and also at the point of her having a dialysis. She also developed constipation, likely as a result of immobility and increased analgesia requirements. Subsequently, she became hypoxic and potentially had a presumed chest infection, which was also treated with IV ceftriaxone. So I guess it came to 5 days of being in hospital, and her pain and her delirium management was not optimized, and the decision was made to refer to the palliative care team for a more holistic approach to her symptoms. And that's when we got involved in her care. So I guess when we saw her, her vital signs were stable. She was clearly very distressed and restless. She was speaking Italian language, calling out and looking very uncomfortable, moving in bed. Our examination was really limited, as we really couldn't examine her with a conscious state. But what we realized that her oral cavity was extremely dry. She had a white coat on her tongue. And we also observed her to continuously be touching her left hip region, indicating some degree of pain. Just some psychosocial background. So she's from home with her daughter, who was a main carer. She had reasonable quality of life. She was ambulant within a four-wheelie frame within the house, and was able to self-care with certain parts of her ADLs. She was non-English speaking background, with Italian being her primary language. She was visually impaired in the left eye, and she was blind in the right eye. But within a home environment, she was functioning reasonably well. She had a hearing aid, and there was some reports of short-term memory loss. There were some reports around carer stress due to recurrent falls and a slow downward trajectory. She was also religious with the Catholic denomination. So what we did for her in the first instance, we decided against any oral option of managing her pain, mainly around the hydration status. It was unreliable in terms of trying to get her to swallow tablets. And we thought a quicker way of trying to optimize her pain would be a parenteral option. So we suggested prior any movement cares, and because it was mainly incident pain that we assumed that she was experiencing, we suggested fentanyl subcut 25 milligrams every 4-hourly PRN, and we see sublingual buprenorphine. And I guess, you know, our thoughts, sublingual buprenorphine with dry mucous membrane, the absorption probably would be compromised and probably not a suitable option for her. Within a few days, we decided to commence on buprenorphine, mainly in the setting of a chronic pain, history of osteoarthritis. And she was also on tapentadol prior to coming in, and we felt that some degree of opioid replacement was required in her setting. We managed to oral thrush, And we focused a lot on some modifiable factors for her delirium, particularly exemptions for family to come in, mainly advocating around her sensory impairment, language barrier. Given the rise in COVID, the hospitals have now restricted families to come in. So that's been a big problem in terms of including family members in patients' care, especially in this situation. But we made exemptions to try and advocate for the family to come in. We suggested bringing hearing aids. We managed constipation with laxatives. And there was a lot of education and support that we provided as a team for family around delirium management. And the main concerns of her daughter, well, pain was not adequately managed. Felt for whatever time that she had left, maintaining her dignity was the focus. Making sure that her mom did not have pain and reducing the level of agitation. As discussed, she was unhappy because of the visitation rights to visit her mom in hospital in this current situation, and clearly felt that her presence would assist in communication, could assist with trying to get care needs done for her mom, and which we advocated, and it happened. And also trying to talk to the daughter around the perception on the delirium experience that she sort of witnessed for the first time. The fact that she had lack of awareness around delirium, the difficulty in understanding the sudden changes that she experiencing her mom being in that restless state, and the feelings of distress and shock. So a lot of time was taken in terms of communicating with family in this case. Before I go to my summary slide, does anyone have any questions, or this is my last slide about the case?
Nisha, it's Gauri here.
Yes.
Did you say that this lady actually came in on ketamine, or it was initiated in hospital?
No, so that was all given in the ambulance.
Oh, okay.
En route.
Yep.
Yeah.
Mm-hmm.
So I guess in summary, this is a 77-year-old lady with end-stage renal failure, felt to have a reasonable quality of life prior admission, admitted to hospital for conservative management of her fractures with a new onset of delirium, likely multifactorial. And I guess the main thing to highlight is pain being a major contributing factor for her delirium, because it was clearly her conscious state improved quite significantly once we got on top of her pain. Unstable, untreated pain can cause a lot of other complications, which is reduced mobility, constipation, chest infection, and this was a sequelae that she sort of developed over a period of days. Pre-existing visual and hearing impairment, I think that's crucial to identify during your initial assessment. Because they are paramount in terms of providing care to your patients, and as well as language barrier. And then what I'd like to highlight in terms of the COVID restrictions, I guess the impact of restrictions on patients and families to provide comfort and regular orientation and therapeutic interventions, which are all sort of human elements of care. This cannot be underestimated, and sometimes it is recognizing this and advocating in a situation like this.
Thank you very much, Nisha, for a fantastic case and beautifully presented. And it really does show how complicated management can be, and in delirium, the management of delirium can be, as you say, it's so often multifactorial, and so often many of the factors are very hard to change. So I open it up for questions or comments or reflections.
Yes, Dr. Kale here.
Dr. Kale.
Hello.
Yes, please.
Dr. Kale.
Yeah.
Because it is written that she had a reasonable quality of life prior to admission, and she had a fall. So the delirium, cause of delirium here is because of extreme pain. So that has to be addressed first. And the language barrier can be managed with reasonable restriction, because the doctor can only speak Italian with all the, as if she is a nurse there, that can be managed, because this language barriers becomes a very problematic thing, because neither the patient is able to explain, neither the caregiver or the medical professional can understand. So these two things should be addressed, then only that delirium can be addressed. And for pain management, my suggestion would be epidural block.
Yeah.
What do you say?
What do you say to an epidural block? Do you think, was it considered in this lady, or was she too agitated, or what, did it come up at all in the discussion of management?
She did have a temporary block in ED that didn't seem to hold her for more than 24 hours. To be honest, we didn't actually think of an epidural block in her case. I think trying to get it down for a block would have been extremely difficult, probably needed some degree of sedation. It was also incident pain, which was managed with fentanyl subcut, and we were sort of didn't go down there, but I think that's probably a good option to think about.
I think too, in like in the Indian, it's kind of, because often opioids are not available, then still the more interventional approaches tend to be used perhaps more in India than they are in Australia. And as you say, Nisha, we sometimes really do struggle here to get those sorts of procedures done in patients, where perhaps with this kind of, incident pain from fracture, it might be. But I think she had a fascial nerve block initially, didn't she? Not a epidural block.
No.
Do you think in India this sort of patient would be more commonly managed with an epidural block? Indian colleagues, what would you do normally there? Dr. Koshi, what would you do in your center, or Dr. Shilpa? To manage fracture pain, incident pain due to fractures in people who are not orthopedically managed?
The settings that I have worked in, there also epidurals are not a very commonly given block, especially for this patient who is delirious and does not understand the language, and she has pain around hip and pubic region. It would be very difficult to make her sit for so long to be able to give an epidural safely. That's my personal comments.
No, thank you. Absolutely. As Nisha said, you'd have to sedate her, and that carries risks as well, doesn't it? And
there are blocks which can be given, and then later on, once the patient is okay, we can place even laterally and give an epidural with the fractured site non-dependent.
Yeah.
That is definitely a possibility.
Yeah.
Okay. But the other thing which struck me was, why 25 microgram fentanyl subcute every 4 hours? Does that subcute have any advantage?
Yeah, Nisha, do you want to talk to that again, about why you chose the subcutaneous parenteral route rather than an oral route for this lady?
Yeah. So I think in her case, we went with a parenteral option rather than oral option, mainly because I think in Australia, we've got sublingual fentanyl as well, which could be an option. But I think in this situation, it was really hard with a conscious state and her dry mucous membrane to administer anything sublingually. So that sort of excluded our oral option of trying to optimize the pain. So we thought a more gentle parenteral option would be a subcutaneous route, and that was used for her. It was more on cares or any movement rather than being provided regularly.
Does that answer the question, Dr. Koshi?
Yeah, ma'am.
Okay.
Nisha, I guess, was it also because of its quick action as well, I guess, as
That's
you
right.
rightly said, yeah, because she was in such uncontrolled pain, I guess, and that age appropriate dose of 25 micrograms every 4 hours, I guess, which is just for the amount of pain she was having, I guess. Yeah. And other thing that just came to her mind was like, maybe at that time, Abstral was not in stock. In Australia, we're having major issues with things going out of stock at the moment as well. So I'm not sure, how old this case is, but there was a point where fentanyl lozenges were out of stock Australia-wide. I just have one comment to make if no one's put their hand up. Not in this lady's case, I guess, she has sacral fractures, but does anyone have any experiences with use of salcotonin, so salmon calcitonin for vertebral fractures? So I've seen that quite often in our practice, perhaps 100 units, 5 to 7 days, once a day, subcut, used for vertebral fracture pain. I've seen that more often. Now, I see it more often now than
You think it's
before.
coming into practice more, Gauri? That's interesting. Shilpa,
Yeah.
did you have a comment on that?
No, I had another question.
Yeah, carry on. Sorry, Dr. Kale, we'll come back to you in a minute. Shilpa?
I just wanted to ask why intravenous acetaminophen was not considered for her. Was there any for pain management, and why are we only going for opioids?
Was she actually in the hospice, Nisha?
Not in the hospice. This was in the renal ward. That's a good thought.
No issues with renal function or dialysis? She was still having dialysis, was she?
Yes, she was dialyzed. Yes, that's right. Yeah.
Well, probably her LFTs were not that great, maybe, that the team thought maybe a high dose of paracetamol might not be a good option for her. Not sure. And again, the acuteness of the pain, perhaps, Panadol is great for baseline pain management. But again, in my little experience, I think, because her pain was so uncontrolled and this lady was most likely wincing, maybe that's why the team thought, go for
Need opioids, yeah.
option first, yeah.
It would seem that she does need some form of opioid. Dr. Kale?
Yes, there's a question for Gauri. Dr. Gauri, hello.
Yes.
Yes, Dr. Kare.
Yeah, you said something for the fracture of this thing. What was that drug?
Salmon calcitonin. So calcitonin, which is derived from salmon, basically the fish. So it's called as salcotonin, basically, or salmon calcitonin.
How does it act?
Good point. I think it is something to do with the bone formation, with the osteoblasts, blasts. Yeah, one of those which build the bone, and definitely blasts, I'm pretty sure. It's something to do with the bone formation, the regeneration of the bone.
But madam, sorry for interruption, but we are talking on acute case. It will take some time.
No, you are spot on, Dr. Kare. This is actually, I have seen that quite often in geriatric setting for sure, for vertebral fractures, mostly vertebral fractures, not for sacral. I have not seen that in any other setting. What I can do is, if everyone's interested, I can share a paper that we actually did a lit review on that. What's the evidence behind this? Because a lot of our geriatricians are liking it lately, and it works. I mean, a 5 to 7 day course of that 100 units. Obviously, we need to be very mindful of the calcium levels. We don't want, because it will affect the calcium levels. But I guess 100 units might not be as much once a day, enough to affect calcium levels. But yes, it does work. Just that short course. I can share that paper afterwards.
Thank you.
Thank you. Great discussion. I guess too, what comes to mind is that for this lady, this is a flag, isn't it, to discuss her goal of care again, and whether or not her hemodialysis was still the best, consistent with goals of care. Did that come up at all, Nisha?
So it came to a point where they were actually trying to sedate her to get the dialysis done. And that's when we sort of had conversations with the treating team, and the decision was, if we have come to that point that she needs sedation to get investigations done, then we should be talking about goals of care. And I think that was sort of mentioned with the family, but they felt that she had a reasonable quality of life, and they felt, let's try and focus on the triggers. And if she sort of didn't come out of it, then we would be going towards talking about goals of care discussions around dialysis.
Because in a way, you start to wonder whether this lady's having pathological fractures in the sense of osteopenia,
yes,
and end-stage renal failure, and really having that whole question of what quality of life is so fascinating, isn't it? To the outsider, you'd raise the question, but for the lady and her family, there's still quality of life there. Great. Well, I think we've covered the topic of delirium very comprehensively, and
just
we're
one
under
last
no
question.
illusions. Pardon, David, Dr. David?
Just one last question.
Yes.
What was to Nisha, what was the pain score pre-treatment, 0 to 10, and what was post-treatment pain score? How well were we able to achieve the pain relief?
So objectively, we didn't use a pain score in her case, pre and post. It was more of just seeing her conscious state, how she was reacting with staff and family. Yeah.
I guess, do you want to comment on the APLI pain score, Anisha? Because the lady herself probably couldn't rate her pain given her delirium. So you're looking at an observer pain score, which is it the APLI pain score?
We didn't actually use that, or that we just subjectively looked at her, and on assessments we could see the change in her state.
But essentially, isn't the APLI pain score the one that is based on the observer's observations? Is that right, Anil? I think it is.
I
correct.
Think you were talking,
that's correct. Yeah. So if the person is whimpering or making sounds, what their behaviour in the bed is looking like, etc. Yes, it is a useful tool, particularly in the geriatric population.
When the patient can't rate their own because of confusion or other problems.
For that, we also use pain aid as well, PAINAD. So pain Alzheimer's disease. That is also a good tool for non-verbal patients. It's called as pain aid. Yeah, pain AD. Yeah, pain aid. Yeah.
Pain aid. Okay.
Yeah.
So we can all Google that one. All right, everyone. Thank you very much. We didn't need a second case. I think we had great discussion with the two, and thank you to our two presenters, Gauri and Nisha. Fantastic job. And as Raja has already put up in the chat,